Welcome to Pathology Coding FAQs, frequently asked questions from subscribers of APF's Pathology Service Coding Handbook. This discussion, compiled by Brenda, editor of the Pathology Service Coding Handbook, utilizes the handbook along with the ICD-10 CM codebook as resources. A commonly submitted question asks for the appropriate diagnosis code assignment when billing for professional component interpretations of clinical lab tests. A subscriber writes, "We perform and bill clinical pathology interpretations from the CMS-approved test list, also known as the presumptive test list. When billing for these interpretations, do we follow the same coding rules as clinical lab or diagnosis coding, that is, bill for the reason the test was performed?" Nearly 20 years ago, Medicare approved a limited number of clinical lab tests that frequently require a pathologic interpretation. Payment for these interpretations is made via the physician fee schedule when the clinical CPT code is billed with modifier 26. Serum protein electrophoresis, CPT code 84165, is a clinical test that's typically interpreted by a pathologist. In our example, the referring physician ordered a serum protein electrophoresis based on the clinical judgment of an immune disorder. The patient's total protein is high, along with the gamma globulin level. The pathologist's interpretation states the presence of a polyclonal increase in gamma globulin with no known paraproteins or monoclonal peaks. The pathology diagnosis is more definitive than the reason the test was ordered. So what ICD code do we assign? Our decision is made easier when we know how the test will be paid. Will the ordered test be paid from the clinical lab fee schedule? When paid off this schedule, the claim must list the primary diagnosis as supplied by the referring physician. Any abnormal result or definitive diagnosis is then listed as a secondary diagnosis code. When the test or service is paid based on the physician fee schedule, the primary diagnosis code is the definitive pathologic diagnosis. There is no need to report the referring physician's clinical diagnosis unless it provides significant and relevant information to support medical necessity. However, the clinical diagnosis from the referring physician is used when a definitive diagnosis is not available. When the test being billed is for a screening Pap test, the primary diagnosis code remains the reason the test was performed, typically reported as a Z code, followed by a secondary diagnosis for any abnormality. This diagnosis order applies only to screening Pap tests that have pathologic interpretations as well. Conversely, when the Pap test is diagnostic in nature, then the definitive pathologic diagnosis is used as the primary diagnosis. Our coding challenge, as presented by the subscriber, is to select the appropriate ICD-10 code when filing a claim for the professional interpretation of the test under CPT code 84165-26. I've listed several codes to choose from, so take a moment to review. When selecting a code, let's remember the rules. This presumptive test interpretation is paid via the physician fee schedule. This means that the primary diagnosis for the pathologist's professional fee is the ICD code associated with the interpretation of the test, the definitive pathologic diagnosis. When the test interpretation is normal, the primary diagnosis is the referring physician's diagnosis for the need of the test. These three diagnosis codes are not the best code choices that describe the pathologic diagnosis. Gammopathy is defined as a disorder of the immune system characterized by abnormally increased levels of immunoglobulins in the blood. The interpretation states no monoclonal peaks detected. Thus, D47.2 monoclonal gammopathy is incorrect. R76.8 is not specific to the abnormal findings supported in the pathologic interpretation. Finally, since the pathologic interpretation is complete, then the referring physician's diagnosis, D89.9, is not the primary diagnosis. D89.0, polyclonal hypergammaglobulinemia, is the correct diagnosis code for billing the pathologic interpretation of this test. The citation from the code book is noted here as a reference. Our next coding challenge is to select the appropriate ICD-10 code or codes when an independent lab files a claim for both components of the serum protein electrophoresis test performed on a non-hospital patient. The lab would be billing CPT code 84165 for the technical component and CPT code 84165-26 for the professional component. Let's refer to the rules for code selection. CPT code 84165 is paid via the clinical fee schedule, so the primary diagnosis for this billing line is the reason the test was ordered. Notice that this claim line uses the diagnosis pointer A to notate ICD code D89.9. But we also know, based on the previous challenge, that CPT code 84165-26 for the professional component is paid via the physician fee schedule. Thus, this claim line uses diagnosis pointer B to notate ICD code D89.0. When the independent lab bills only the technical component, CPT code 84165 with no modifier will be filed using the referring physician's diagnosis code D89.9. I hope this FAQ has provided valuable coding knowledge to you and your staff. Please contact me with any questions or future coding challenges. Stay safe, stay healthy.